My
Yeah.
yeah, my heartfelt gratitude, ma'am. I heartily thank AIO Scientific Committee, Namrata ma'am, Dr. Rajesh sir, Joshi Eye Institute for giving me such a wonderful opportunity to talk on this platform during such difficult times. So today I'm going to talk on one more entity called as ocular hypertension, which we as glaucoma practitioners face a problem in our day-to-day practice. That is more than a problem, I can call it as a dilemma. So by definition, it is defined as a condition where the intraocular pressure is greater than 21 mmHg. There is no evidence of optic nerve damage or associated visual field defects, and the angles are open. There are no associated systemic or ocular cause for raised IOP. It is also referred to as a glaucoma suspect, open angle without any damage, or it is also called as early glaucoma. When you look at the general population, majority of the people, they constitute this blue part, they constitute portion called as ocular hypertension. That is just IOP is raised and without any associated defects, and only a small proportion among them will progress into primary open angle glaucoma, that is with both elevated intraocular pressure and damage. So what to do with these patients? How often should be they examined? Is preventative treatment effective in these conditions? And who all should be treated? Will be discussed in our subsequent slides. So once when we go through our epidemiology, 4 to 10% population over 40 years present with this condition. Among them 18.4% in Black African descent, 13% in mixed race, and 4.6% in whites. In southern India, prevalence of 1.1% in individuals above 40 years of age has been reported. The exact pathophysiology of elevated intraocular pressure in ocular hypertension is still unknown. It has been concluded that myocilin MYOC gene mutations have been found and determined to cause protein misfolding, making the trabecular meshwork cells dysfunctional, with subsequent decrease in the outflow facility and marked elevation of IOP. So then came to our rescue this ocular hypertension treatment study, which was conducted between 1994 and 1996. The primary purpose of the follow-up study was to determine whether delaying treatment resulted in persistently increased risk of conversion to glaucoma even after initiation of treatment. There were mainly two objectives. One was to evaluate the safety and efficacy of topical ocular hypertensive medications in preventing or delaying onset of visual field loss or optic nerve damage in subjects with ocular hypertension. The second was to identify the baseline demographic and clinical factors that predict which participants will develop POH. So this was a randomized control trial which was initiated in 1994. There were two groups. One was medication group where the IOP was lowered to 20% or less than 24 mmHg. The other group included no topical treatment to lower IOP, and monitoring was carried up to 2 years with visual fields done every 6 monthly, and stereoscopic disc photos were taken annually. 3 consecutive visual fields or 2 consecutive sets of optic disc photographs were reproduced as if were included in this criteria, and POAG was suspected when you could found visual field and or optic disc changes attributing to POAG. So the results of this study were at 5 years follow-up, incidence of POAG was found in 9.5% in controls and 4.4% in treatment group, and 22.5% decrease was found in IOP in the treatment group. So the clinical useful points from OHTS which we could draw were whether to treat all or whether treat no one or treat some, or is the treatment effective. So when we these are the risk factors which are obtained from the OHTS study, which are prospectively proven risk factors. The main important risk factor is corneas, the pachymetry of the corneas, as already discussed. If it is less than 535 microns, elevated intraocular pressures, increasing age, vertical cupping of the optic nerve, which should be more than 0.6 CDR ratio, increased pattern standard deviation on threshold perimetries, abnormalities in the optic nerve with SLO, and pseudoexfoliation. These are the associated or the putative risk factors, which include the social demographic factors, associated comorbidities, which could be coronary artery disease, atherosclerosis, or cardiovascular diseases, endocrinal diseases, and other miscellaneous ocular conditions like pigment dispersions, CRVOs. So we will discuss the important 7 risk factors which lead the conversion from OHT patient to a POG. That is, relative risk of POAG increased by 81% for every 40 microns decrease in the central corneal thickness. CCT less than 555 microns were found to be at a greater risk than eyes with CCT more than 588. This was the one of the risk factors. Second is the IOP. Greater than 22 mmHg is a positive predictive factor for development of POAG. And individuals with older age had a greater risk for conversion to glaucoma. Percentage of patients who developed glaucoma during study, that is ocular hypertension study, when correlated by IOP and CCT is CCT less than 555 and IOP greater than 25 had a risk factor of 36%. Whereas CCT greater than 588 and IOP greater than 25 had just risk of 6%. When we compare CCT with CD ratio, CCT less than 555 and CD ratio of 0.5 had a risk factor of 22%. Whereas CCT greater than 588 and CD ratio of greater than 0.5 had risk factor of 8%. And it was OHTS also found that pattern standard deviation on standard automated perimetry correlated with increased risk of progression to POAG. With 0.2 dB increase in pattern standard deviation, 22% increase in relative risk was found in OHTS. Increased vertical and horizontal cup disc ratio is also a risk factor for progression. Increase in CDR by 0.1 leads to 32% and 27% increase in relative risk in vertical and horizontal cupping, respectively. So these factors which were concluded from the OHTS study which form risk factors are elevated IOP, cupping of the optic disc, increasing age, thin cornea, increased pattern standard deviation. Others were just associated factors. So always one should have a diagnosis of exclusion. That is, history taking becomes very important here to rule out any secondary cause for elevated IOP like trauma or any previous history of steroid usage, which could be in any form, oral steroids, topical steroids, or steroids in form of ointments or inhalers for asthmatic conditions and etc. And usage of antihypertensives as they cause IOP fluctuations. Advanced age greater than 50 years and myopic patient and positive family history, severity of glaucoma in a first degree relative, all should be considered. Slit lamp microscopy, which includes corneal examination, is also very important. Microcystic edema can be found with a sudden elevation of IOP, KPs, pigment on the endothelium, Krukenberg spindle, and congenital and other anomalies suggest a secondary cause of elevated IOP, which help us to differentiate it from OHTs. Anterior chamber should also be examined to assess for an absence of cells or flare, hyphema, foreign bodies, and angle closure. As already told by Sir, 40%, there are 40% of chances that we miss a case of angle closure. Iris atrophy, synechiae, rubeosis, ectropia uvea, iris bombay, difference in the iris coloration bilaterally, which is most commonly seen in Fuchs heterochromic iridocyclitis or PXF material, we tend to miss. Lens should be assessed for an abscess of phacomorphic, PXF, Morgagnian, or a phacolytic cataract. Medeiros and colleagues, they developed a risk calculator for OHT that may progress to glaucoma. This is called a STAR2, that is scoring tool for assessing risk, which has age in years, intraocular pressure in mmHg, CCT in micron meters, pattern standard deviation, CD ratio, that is vertical. This is in this illustration, a 72-year-old open angle glaucoma suspect with an IOP 29 mmHg, a corneal thickness of 501 microns, and a pattern standard deviation on threshold perimetry of 1.75 and a cup disc ratio of 0.7 has a 67% chance of developing into frank open angle glaucoma within 5 years. And that's how it can be used. So according to this OHTS study, these OHT patients are divided into 3 categories. That is high risk, who need immediate treatment. That those include retinal fiber layer defects, parapapillary changes, IOP greater than 30 mmHg, IOP greater than 26 mmHg with central corneal thickness less than 555 microns, vertical cup disc ratio 0.4 to 1 or more with central corneal thickness less than 555 microns. Moderate risk, who require annual follow-up. IOP greater than 24 to 29 mmHg without retinal nerve fiber layer damage. IOP of 22 to 25 mmHg with central corneal thickness less than 555, vertical cup disc ratio 0.4 to 1 or more with a central corneal thickness between 555 to 588 microns, family history of POAG in first degree relative and high myopia. Low risk who require follow-up every 2 years, that is IOP between 20 to 23 year mmHg with central corneal thickness more than 588 microns and vertical cup disc ratio of 0.4 with central corneal thickness of more than 588, that is thicker cornea. So I would like to conclude my talk by presenting these last three take-home messages slides, that is how to diagnose, when to treat and how to treat it and when to refer it. So how to diagnose will be by careful slit lamp examination by doing a proper gonioscopy, IOP with greater than 21 mmHg, pachymetry, disc evaluation, fundus examination to rule out any secondary causes and associated RNFL defects, visual fields or automated perimetry testing and other tests like OCT, HRT and GDS. When to treat? Considering the low rate of progression to POEG and cost of ocular hypertensive medications, long-term compliance issues, and side effect of drugs, not every case of ocular hypertension is subjected to treatment with hypotensives. Treatment is recommended only in high-risk groups. Other possible indications for treatment include one-night patient, young patient who will be exposed to high pressures for many years, unreliable visual or optic disc assessment, patient who is in content with treatment initiated by another physician and tolerating medication well, an ocular hypertension patient who desires treatment, and ocular hypertension patient who has developed vascular occlusion in the other eye. How to treat? Lowering of IOP by at least 20% is recommended. Topical beta blockers or prostaglandin analogs are usually the preferred agents. Patients with moderate risk of progression should be monitored closely and treatment is initiated with the earliest sign of glaucomatous damage. Monotherapy is preferred with a maximum of 2 medications at time. If not reducing, a selective laser trabeculoplasty can be used. Aggressive therapy should never be tried. And when to refer? Early recognition and treatment of high-risk patients can limit the visual disability due to POEG. Frequency doubling perimetry or short wavelength automated perimetry detects glaucomatous damage at a very early stage, that is 4 years before the changes appear on a white-on-white perimetry. Hence, for patients under monitoring, FDP or SWAP may be beneficial in the early initiation of treatment. So, I would like to conclude my talk by reminding everyone of the logo of this year's Glaucoma Week, that is, World is Bright, so save your sight. I urge you all to instill the importance of regular eye checkup after 40 years in all your patients to save from this silent thief of vision and let it spread to as many as possible through the word of mouth. Thank you.
Thank you.